Good? Okay. So thank you, Lisa, for inviting me, and thank you for coming. I'm actually really honored and fairly daunted to be in this crowd of esteemed medical educators who I've looked up to for a long time. So I'm going to give you a little bit of our experience in the medicine department, talking about cultural competency to the medical health staff. So this is up higher. I'll just stand. Hello. Fine. I have to speak into here too. Okay. Sorry. Okay. Sorry. I guess I'll have to stand behind the podium then. It's a little odd, but okay. So anyway, just to give you a little sense of what we've been doing in graduate medical education for the internal medicine health staff. So what I'm going to try to talk about relatively quickly today, but please don't hesitate to stop if you have any questions or any comments, which we would really welcome, is to talk about some aspects of cultural competency and how we've thought about it. We're going to touch on disparities in healthcare, the explanatory model, and health literacy. I'm going to define community-oriented primary care, and then hopefully get some people in this room to help me brainstorm of ways to sort of teach cultural competency and community outreach as aspects of professional development as we train our physicians. So cultural competency, there's really no one great definition. This is the one I sort of like. It's a set of skills that allow someone to increase their understanding and appreciation of cultural differences between groups with the purpose of being able to communicate better. And that's not in this slide, but really the main purpose is so that one can facilitate better communication between people, and not just patients and physicians, but between people. And so when you look at cultural competency, people think of it also as a way to improve the quality of care to our patients and to help reduce disparities in care. And there are studies that have shown that patient-physician communication is associated with patient satisfaction, with their adherence to medications and to physician instructions, and to also health outcomes. And so that poor physician communication with patients decreases all of these factors. So the rationale behind developing our curriculum now about 6 or 7 years ago was primarily that there wasn't any prior formal curriculum in our internal medicine residency program to really address cultural competency. And so this was to fill a gap. We also really felt that community outreach and education together was an integral part to developing what it means to be a professional physician. So that includes certain aspects of advocacy, which I'm not going to highlight, but want to just mention today. And that the group of us who developed this curriculum, we really felt that community outreach was a macrocosm of what an individual patient-physician relationship should be like and what that communication is in a culturally competent way. So briefly, and I'm going to run through these quickly because I think many people in this room already know this, but East Harlem and the Upper East Side is incredibly diverse, very different groups of patients. There's huge differences in the demographics, in the morbidity, mortality, and access to care. They're very different groups of patients in terms of their subjective views of their own health. And so they really help us to illustrate for our trainees these aspects of health disparities. I'm just going to briefly run through them. When you look at the Upper East Side, so this is data that's a little bit old and almost, 8 years old now. 200,000 people on the Upper East Side, 100,000 people in East Harlem, so by half, 82% of people living on the Upper East Side are Caucasian. That's in comparison to essentially 10% in East Harlem, with the primary component of people in East Harlem being either Hispanic or African American. The death rate is double in East Harlem compared to the Upper East Side. those living in poverty is 5 times greater in East Harlem than in the Upper East Side. The percentage of uninsured, and then those who consider themselves to be in poor health, 1 in 3 compared to 1 in 10, so threefold different. So again, very different patient population.
The difference between being unhealthy and being in poor health? Like, why did you use that 2 different terms?
That was probably just to mix it up a little bit, but it is in poor health. But thank you. When you look at the statistics, this is again from the New York City Department of Health, and this doesn't project that well. You can see that, in East Harlem, this is compared to the national goal. In East Harlem, more people do not get physical activity, and many, many more people are obese. And many, many more people, twice the amount, in East Harlem compared to New York City, have diabetes. Right? This is in contrast to the Upper East Side, where the percentage of those who don't have physical activity is less than the overall New York population. The percentage of obesity is also less than the overall New York population, and then the rates of diabetes are also less than the overall New York City population. So very different when you look at these numbers, the 15% of diabetes compared to 2% in these two patient groups. So our curriculum, is a 3-year-long longitudinal curriculum developed and delivered to the internal medicine health staff residents during their outpatient block. It incorporates issues of cultural competency in the greater scope of community outreach and patient education. And so what it is, and this is a breakdown of how it looks, it has since changed to some degree, and I can talk about that a little bit. But in its sort of initial mode, this is what we did. So in the fall, we did a neighborhood tour of East Harlem, which is very similar to the tour that the students get, and David Thomas did that tour for us. In the spring, we did a afternoon interactive small group session with the first year. These are interns again, PG by 1, to define what is culture, to help them self-assess their own culture, and to review some literature about racial and ethnic disparities. And so I want to, again, touch on the competencies that are being addressed with each of these. In the second year, it was a series of 3 small group sessions in 3 different afternoons, during which, in one, we talked about health literacy and reviewed the literature and did some role play. In the second, we talked about the explanatory model and reviewed some literature. And in the last, we talked about how explanatory models also can lead to complementary and alternative medication use. And then in the third year, again during the outpatient block, we discussed barriers to effective health education, and we gave them tips for delivering a health education talk or discussion in a group setting. And then they would go out to perform these talks in senior centers or in community groups and videotape themselves doing so and come back and discuss it and debrief it. So very briefly, a very quick run through about the curriculum itself. Is there a question? Yes.
Do all of the trainees have an ambulatory block in the spring of each year?
Yes. So all of the trainees have an ambulatory block in the fall of each year and in the spring of each year. They all get the content. Yeah. Pete. Can I get there? Do you mind? No, I can. Okay. Okay. No, it's okay. I'll. All right. So quickly, disparities in healthcare, which I don't think I need to have to explain to too many people in here. This was really based out of the Institute of Medicine's Unequal Treatment Report. It was published almost 10 years ago now, which basically found disparities across a wide range of diseases and wide range of clinic settings, and that showed that disparities are associated with a higher rate of mortality among minorities. Okay, so that's basically the take-home message. Some of the things that you can see, and again, this is relatively older, but unfortunately, some of these things still hold, and I didn't show any of the newer slides that we actually talk about. But you can see that, and we're just looking at black and white here, because data in the late 1990s and early 200s really just looked at black and white. Data now, when you look at disparity literature, at least starts to bring in different ethnicities and cultures, so black, white, and non-white Hispanic, and every once in a while they include the Asian. But in general, you can basically see that those who are receiving preventive services for example, breast screening or eye exams, those getting beta blockers or having follow-up, it's lower. So there's a disparity. And it exists in multiple ways, and just showing one slide for it, in multiple dimensions, from catheterizations to surgeries to getting narcotics or opioids in the emergency room when you come in with a broken limb. So disparities exist, and they still exist. And their conclusion, the Institute of Medicine, was that although a myriad of sources do contribute to these disparities, there is some evidence to suggest that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to the differences in care. That was what they said. And so what they recommended was to increase healthcare providers' awareness of disparities in healthcare, and specifically to integrate cross-cultural education into the training of all current and future health professionals. So that was sort of the call for why we wanted to make sure that this was a topic and that was included in the curriculum, and that curriculum existed. So to get to Peace Corps, so we talk a little bit about that the first year. We talk about what is culture, and we bring up a lot of examples of where disparities exist and why they might exist. The second year we talk about explanatory models. And so what is an explanatory model? So an explanatory model, this is based on Arthur Kleinman's work in the mid-70s. He's a psychiatrist and an anthropologist. Is a patient's concept of their illness, its causes, and its possible treatment. And so basically it's what the patient thinks about what is causing their illness. So we have, our Western, very pathophysiologic-based view of, what's causing the diabetes. And so I have this great story of when we did this with one of the residents who then had to go and ask some of these questions to their patients. And we talk about, how culture influences the behavior, how it can define what's normal or abnormal, how it can provide what, who is the patient and what you do. Do you go to the Botanica first? Do you try and take chicken soup first? Do you suck on the zinc lozenge first before you come and see the physician? Or do you come and see the physician when you have a temp of 99.5 because that's not normal? There are certain predictive behavioral ultimacy that we go over, but the story I wanted to talk about in terms of what's abnormal, what the cause of is, we had a resident when he did this a number of years ago now, talk about diabetes to their patient and used the explanatory model questions to ask, I didn't put them in there, sorry, to ask about what this patient's conception of the illness was. And he said, what do you call your disease? Sort of one of the first questions. The patient said sugar. I call my problem sugar. So what causes your disease? And the patient said, well, being around too much sugar. Which makes sense. And so he probed a little further, like, well, what do you mean? And she said, well, I grew up in the Caribbean in the sugarcane fields, and I was always surrounded by sugar. And that's why I got diabetes. And he said, okay. And this was a patient he had had some trouble with because it was a patient who had been non-adherent with their medications, and the diabetes medications in particular. And so he said, so what about taking your medicines? She's like, well, yeah, I take my medicines when I'm there because I have sugar all around me. But when I come back to New York, I'm not surrounded by sugar. And so she called her disease sugar, and her explanatory model was that having sugar cane fields and being surrounded by sugar, but not the ingestion of sugar, but being surrounded by sugar was what was causing her diabetes. And so having that knowledge, he was able to go back and try to explain to her what his concept of what causes diabetes was, to try and basically be on the same page with your patient and not be talking in two very different universes. So that's sort of a little anecdotal example of how explanatory models can work. We do talk about patient beliefs and how that can modify their behaviors. We go through a number of articles and abstracts, which I'm not going to bore you with, about how a patient's belief can really affect their behavior. And so if you don't think The first one actually comes straight out of Sinai, with a group of patients here that were hospitalized for asthma and surveying them over the course of the year, and finding that half of these patients who had moderate to severe asthma had been intubated. A third of them had been intubated in the past for their asthma. Didn't believe they had asthma unless they had symptoms. And so if you don't think you have asthma unless you actually have symptoms, you're much less likely to be adherent with your chronic inhaled corticosteroids. And so if you have certain beliefs about your medications, or if you have certain beliefs about your illness, you will behave differently. So it's just a way to illustrate to the residents that getting a sense of where your patients are and what they believe about their disease and about their medications really has a very large impact on how they behave. I just put them in. I just put them in the wrong order. So these are some of the questions you can ask to elicit an explanatory model. So what do you think caused it? When do you think it started? What are the problems? What treatment do you think you should receive? What do you fear most? And then we also do a session on health literacy, because I think that our group really feels that the ability to understand material that's given to you in written form and also in verbal form really makes an impact on how you are able to take care of yourself. And so we go over some aspects of literacy. So when you look at health literacy, the definition is the ability to read, understand, and use health information needed to make appropriate health decisions. And it's influenced by a number of things. It's influenced by all of these things: education, language, socioeconomic status, culture, age, geography. But all of these attributes actually fall under what we considered in our first year as components of culture. And it affects patients' perception of health. It affects their access to care, their experience with their medications, and their behaviors and their outcomes in the end. So some brief overview of health literacy, which many of you probably already know about. This initially came from a 1992 Department of Education study about adult health literacy, and basically found that 50% of Americans are either functionally or marginally literate. So functionally illiterate or marginally literate. So this slide didn't come out exactly the way I wanted. And so they could do things like sign your name or fill out a Social Security application, but they weren't actually able to write a paragraph. And that's a huge chunk of our population. And that when you look at issues about health literacy and determinants of health literacy, things that increase your risk for having lower literacy include things like being of minority race, having lower socioeconomic status, having lower education, being a recent immigrant, things that affect so many of our patients. And whenever we present these to the residents, they're shocked by this number when it's 50%. People are like, oh, it's 10%. Oh, no, it's 30%. I'm a real pessimist. And when we give them the number, that's 50% of people that in the U.S., all comers, adults, self-identified as English-speaking, who are, by this criteria, marginally literate. People are really surprised, and I think really think a lot about how they're communicating with their patients. And you see the little light bulb go off. Maybe it's because they haven't heard about this before, although I know the med school is doing more and more with health literacy. But they're like, oh, no wonder they're not taking their medicines. And the residents, meanwhile, are trying so hard and think that they're doing this great job by printing out some of these handouts or up-to-date reports or something for their patient to take home with, because they don't have enough time in clinic to actually explain it in detail because they're so pressed for time. So they print out these wonderful reports, and they're astounded when we do this with them to find out that those reports probably didn't do very much, because all comers, half the patients probably weren't able to really fully read them. So just something that we talk about. When you look at outcomes, there are a ton, actually, and I'm just briefly going to touch on a couple of them. The main one I really want to show is that you look at literacy by itself, and you control for all these other factors: SES, education, comorbidities, functional status, depression, self-related health behaviors. Literacy by itself is independently associated with an almost twofold increase in 5-year mortality in the elderly. And these are elderly who, when they were initially enrolled, were functionally and cognitively intact community-dwelling elders. So literacy is a big issue. And we point that out to the residents when we go over this. And we talk and help them go through some steps to improve communication. And so again, this falls under the rubric of really thinking about teaching about culture and teaching about cultural competency is ways to help improve communication. And so we don't actually teach them ways to help determine whether or not someone's of lower literacy. We really stress with them that these methods of communication should really be universally applied with everyone that you're communicating with. And so very straightforward and simple tips, like just slowing down when you talk, using non-medical language. We think that we go through medical school and we go through 4 years of learning our new culture, of becoming a doctor, and learning a whole new vocabulary. And so whereas you would in the past say, high blood pressure, now saying hypertension. Whereas in the past maybe you would say, your, intestines or your gut, saying, oh, it's your colon, right? Or your xiphoid process, or, just all of these fancy medical terms that I see when I teach ASM2 the second year struggling to get into their heads and learn. All of a sudden, you forget that by the time you're a resident, that half, 3/4, 5/6 of the lay public does not know what subxiphoid means, and so what epigastric pain means, right? So having to unlearn some of the language that you've worked so hard to learn, I think, is sometimes challenging for the residents when they do this. We talk to them about showing or drawing pictures, limiting the amount of information provided, using the key track technique, so having the patient tell them, if you were to go home and talk to your spouse, your daughter, about what we just talked about, what would you say? Just checking for comprehension. And then, really making sure that we're not disparaging people or making assumptions about anything when we talk to them. And then lastly, I want to go over our third year curriculum, which is really based on a community-oriented primary care model and doing some community outreach. And so a community-oriented primary care is practicing primary care with the health of the community in mind. And it's accomplished through the planned integration of public health practice with the delivery of primary care services. So that's really sort of the crux of community-oriented primary care. And to really understand that, and I'm looking at two different docs here who don't need to tell you this, that health is more than just medical care and more than your biologics, but all these other social determinants of health, like your housing, your employment, your social equity, really affect health. And we try to sort of have the residents think about that a little bit. Although by the time they're in third year, to be perfectly honest, they're not always that willing to hear this. Just further defined, it places health promotion, disease prevention, and it's been really instrumental in the development of these U.S. Community health centers. And it is the foundation of global health outreach programs. So what do you do when you're looking at community outreach, and how does it equal patient care? So you define your community. So, you need to know what your community is. And when you're doing primary care and you're taking care of patients, I guess it doesn't have to be primary care. But I'm a primary care provider, so that's the way I think. You define, who is your patient? Who's your community? Who's your patient? You assess their needs, right? In the community, you can do needs assessments, you can do epidemiology. In patient care and in primary care, you need to be aware of what their culture is and what their needs are. What can I help you with? Not, I need to fix your diabetes, because they may not care about the diabetes. They may just care about, the gout in their elbow that's killing them. So what are their needs? And then you target intervention to their needs. So you take a look and try and help address their needs rather than what you think they need help with. And then you try to measure your intervention. So again, challenges for community-oriented primary care currently in our healthcare system. There's a huge sort of, I don't want to say division, even though I wrote division, but there's not, we're not always on the same page when we talk about public health versus clinical practice. And our healthcare system is fragmented. our reimbursement system, as we all know, favors clinical services and technological procedures. A cath is going to get you a lot more money than, having your patient take an aspirin and a beta blocker and a statin to prevent their recurrent heart attack. So the sort of healthcare politics of it does not reward prevention necessarily, although that may change. And then from a community-oriented standpoint, our profession traditionally, as we've been trained as physicians, has really been focused on the care of the individual patient and less at looking at the whole population. And so when we think about how to sort of implement community-oriented primary care into some of this curriculum that we're talking about in terms of being culturally competent and understanding that it's important for just not the patient, but to understand their broader community and to try and make an impact on it, we do try to market the prevention aspect. And we want to help enhance the education of our community and of our patients through this collaboration and communication. And we hope that, when you look at COPC in the broader terms, that you can look at primary care beyond just individual. So what did we do? So in our third year, we had our residents go to local senior centers or community centers, and they went in groups of 3 to discuss hypertension or to discuss getting a colonoscopy. Or we had one where they discussed vision problems, and so they all came in and looked up, age-related macular degeneration and glaucoma, and that I thought was actually really amazing because they knew all about wet versus dry AMD, and when you see them they film themselves. They don't film any of the participants, any of the seniors or any of the community participants. So you just see themselves, and you can see that there's a little bit of a pause because someone's up there trying. And I'm not going to name names. One of the residents is up and he's so interested in trying to tell you about the difference between wet versus dry AMD, and you can just sort of sense that it isn't going over that well with the community participants because they just wanted to know what to do about their vision loss, or what to do to prevent any vision loss. And he was so interested in sharing all this new information that he found out for this talk. And it helped to highlight that, sometimes we go into these patient visits and we're so focused on getting their blood pressure under control or getting their A1C less than 7, and forget that they're really interested in, their arthritis in their knee, and that they're not going to really be able to control their blood pressure until you help them do something for their knee. So it is very interesting when we have looked at these and come back to debrief them. We try to do this to show that outreach is a dialogue. And that when you go out to speak to a community, you might have a topic in mind. But if your community is not interested, then you're just sort of standing up there. And it's not an interchange. Which I realize I'm doing now. Instead of asking you what you wanted to learn. As I'm sitting up here. But anyway, I'm going to plow on. So, we really want to point out to them that very similar skills that you use in your patient care practice, in your individual practice, can be used and extrapolated to the community. That when you go out to the community, you need to get an idea of what their cultural basis is and get an idea of what they need. And so that we want to be responsive to what they want. So some evaluation, and this is going to be brief because we've done some and not actually, we've collected them but not actually fully evaluated them. So from just anecdotal responses to the numeric surveys, people have generally been reasonably positive, although more recently in the last few years, less positive. And I think there are a number of reasons for that. As you can see, our overall rating in 2004 was reasonably high, and it's fallen in 2009. And I think there are a couple of reasons. One is the medical school is doing an amazing job in getting more and more students aware of cultural issues. And so by the time they come to us in residency, those who went here, at least, are like, been there, done that. Why am I hearing it again? And it makes it challenging for us when we're teaching it to residents, because there are, of course, many of our residents who didn't train here, and trained in places where they didn't have such a focus on cultural issues. And so how do you balance, and this is always, I'm looking at Lisa as I'm thinking about resident as teacher, how do you teach to a group of mixed learners? How do you sort of convey some of these topics that are important, we think, but may have already been conveyed at an earlier stage. And it's a little bit different because when you're teaching on wards and you're teaching to a third-year medical student versus a sub-I versus an intern versus a resident, they are in the hierarchical medicine, in different roles. When you're teaching a group of second-year residents or when you're teaching a group of first-year residents, they're all sort of in the same place hierarchically. But knowledge-wise, they can vary greatly. And so that is somewhat challenging because some people come in and they know this stuff already and believe it. Some people come in and they know some of it already but are poo-pooing it. And some people come in and they haven't heard any of it because it just wasn't addressed in their medical school curriculum at all. So how to sort of make it relevant to everybody without being redundant to those who've already had it has been one of our challenges of recent years. One of the other things I want to show to you guys and get a sense of it is, this was about 3 years ago we started this, and so we have data for 2 years of this and not for last year because of various reasons, where, as I said, in the third year our residents go out and do this community talk, and we have them videotape themselves. And they are to review their videotape, and when they come back to do the debriefing, show us their first 5 minutes, their last 5 minutes, and a 10-minute segment somewhere in between. So we have 2 groups reviewing their case because it's a group of 6 residents. And what we've done is created a 21-point checklist to evaluate the team and the individual residents when they perform with community outreach. And so we included domains of setting the stage, understanding the participant's perspective, providing information, and closure. And so I'll show you one of them and what it looks like. So for example, this is one of the evaluations that they can do as they look at the video and evaluate one another. So, does the team, when they're giving the outreach talk, establish this environment to help elicit the participants' health beliefs? Do they discuss complementary and alternative medications or remedies in a non-judgmental way? Right? So as a team, do they do this or do they not? And it's either a yes or a no. And then individually, for the residents in each group, do they allow participants to complete a statement without interruption? They either do it, in which case you check a box, or they don't, in which case you leave the box blank. Do they summarize the statements for the audience? So it's sort of not quite checking for comprehension, because that's number 9, but do they summarize what they understand of what has been told? Do they check for understanding, and do they ask any clarifying questions? So we created this. We've evaluated 2 groups of third years who have gone through this and evaluated the videotapes, and plan to at some point, if I get around to it ever, to actually analyze the data to see how one evaluates oneself, because when you do this you can evaluate yourself, because everyone has a sheet for themselves, how you evaluate your colleagues who you did the presentation with, how your colleagues who didn't do the presentation evaluate you, and how the evaluator, the faculty member, evaluates the team and the individual participants to see if there's any correlation with this. So that's sort of in process. Some barriers, again, to talk about and to really try and get this group's ideas about ways to overcome them. The first is this issue of resident interest. This is a topic that's important to them. How to make it important to them. How to make it important to those who've already had it and make it still new and fresh. At the same time, being able to provide information that's basic to those who may not have had it has been a challenge. That will take time, obviously, in our department's commitment to supporting this curriculum in terms of giving faculty time to teach the curriculum has been of late relatively challenging. Finding the community sites. So that's been tricky, and it is why it did not happen this past year in 2010, because there were some sites that sometimes would have one person show up. And so we would send 3 residents out to do this talk, and they'd have one community member show up. And there are these residents talking to the 1 or 2 community member. So that's been challenging. In trying to find other sites that might be interested or wanting to get involved. And then lastly, which we presented briefly, is how to evaluate the outcomes of this curriculum, right? Beyond just resident knowledge. Are there any patient outcomes that we can look at to see that this might be making an impact, which is, of course, the Holy Grail. So are there other ways to evaluate what are the potential, what could be the outcomes of this curriculum? So I'm leaving this open for some ideas. And before I do, I really want to thank my collaborators for this. David Alfondre, who has left, who was a medical student here, and then was an attending with me over in IMA for many years. John Rick, who is a visiting doc, Teresa Farayon, who's also a visiting doc, and then David Thomas, and they all had an enormous amount of input in the development of this curriculum, including the implementation and the evaluation that you've seen. So thank you for your attention. I would welcome any thoughts or ideas.
More interested in it if it had a closer connection to them. And so my thought was that I know for myself, my family, who is literate, I think has poor health literacy. And I wonder if it would be interesting to have them do an assignment where they go into the family member with a chronic disease and ask the same explanatory model questions. And I don't know what you get back, but I know for myself what I would get back. I mean, it sort of surprises us, I think, when people who actually are literate, even if their health literacy is not so great. And so then can they extrapolate that to maybe having a better connection to people who do not come from their own background and perspective.
That's interesting. Yes.
Thank you very much for those great talk. There was one big buzzword which I didn't hear you mention, and I think it's very relevant to 2011. How about internet? When you talk about medical or healthcare intellect in a person, I'm sure there's probably, we see all the time in our clinics, patients, I read this on the internet, I looked at this, and I always tell them, take that as a grain of salt. But I think that has a very big role today in how people look at disease and how they look at lung disease, how you actually educate people, because they're going to do it themselves. Some of them won't. Some of them need help with it. I wonder how that plays involved with it.
Yeah, absolutely. I think that certainly when we talk about the studies that we looked at with regards to health literacy, since they were done in 1992, the internet was much less of a presence. It was repeated again in 2002. But again, the internet does not have such a big presence then as it does now. So I think that that is definitely something that is worthwhile to keep in mind.
It seems like you're trying to look too hard to find sites, whereas IMA is like a circus. There's a billion people there. I just have sections there in the waiting room.
It's a good idea. It's definitely a good thought. It's a captive audience. I guess the question for me is sort of how to or the emergency room. Picking the topics to have them. I hadn't thought of that. I think that's a great. Yeah.
It'd be a great place to recruit people to try. Yeah. Health policy goes over there all the time.
Yes, we have a ton of patient recruiters.
This talk could have been given when I was in medical school, and the same talk, but nobody ever professionalism would be the topic. And, as a pediatrician, I guess I'm used to drawing pictures and using non-medical words a lot. When I do that, I did that with in Franklin Park area. I did that when I worked at Elmhurst. And it's so that I think you've chosen all these things, culture. But to me, maybe the residents, if they think like I do, would think, well, what does this do with culture exactly? And so maybe it's a little bit of, in their mind, a bit of false advertising. Because I want to know what people, Hispanic people in these parks especially, what's the difference between that and black people and Chinese people and Jewish people and, these people who live in cupping and these people who do, I want to know some more content being as simple as that.
Yeah, that actually is, that has actually been something that's come up multiple times, and I'm glad you asked it. And traditionally, when you look at some of the other courses in either various graduate medical programs or undergraduate medical programs that look at culture, they do very much sort of define various ethnic groups and talk about general practices or beliefs. And we distinctly steered away from that. And you're right, maybe what we should do is relabel it. The reason we steered away from that is we really wanted to focus on giving our trainees the skills to be able to elicit patients' beliefs and cultural issues, and many of which I think are related to their culture, especially to define culture as a shared set of beliefs and traditions, and not necessarily particular to either the Puerto Ricans versus the Dominicans, or the Chinese from mainland China versus the Taiwanese, right? Because we wanted to give them the skills to be able to find that out for themselves rather than spoon feed them data that could be potentially wrong, and worse for us when we thought about it, potentially stereotyping people. And we really wanted to have the residents not think, okay, so they're from the Dominican, and that means they're really going to believe in, Santeria, and that's why they're going to be using, voodoo medicine, or however you want to define any of the stereotypes that we had. So I'm glad you brought it up, because it has definitely been something that comes up every time we talk about it, and it is one of the criticisms that we get, is, well, why don't you just tell us what this population is like and what we should do? And so that has been my answer and continues to be my answer for why we choose not to do that.
I guess like everything else, it's the middle ground. You say that you don't want to overgeneralize, but some people in this culture use it, and if they don't mention it, they need to figure out a way to steer the discussion in that direction to make sure either if they're embarrassed to tell you that they, I was taking care of a doctor's kid in Elmhurst, and the grandmother had done cupping. This was Russian, and the grandma had stolen the kid, done cupping, and the mother was mortified. She wasn't going to get away with not doing cupping, and of course the Adobe intern wanted requested people for charms. So I really looked at it sort of cupping, but so maybe there's sort of a middle ground where you don't overplay it, but make sure people understand that there may be things that you get at that they don't mention you may want to.
Sure, that's it. Yeah.
This is wonderful. I was sitting here thinking along the same line as Scott. I was in practice, I started training almost 20 years before Medicare, and was in practice for 10 years before Medicare. And I think that Medicare has been part of the downfall, because it was supposed to be the great equalizer, and it really wasn't. And I think that the great divide has gotten much wider over the last 50 years. And I think that the culture of the culture has changed. And I think the culture of the patients that we're dealing with has changed very dramatically over the last 50 or 60 years. And I think Peter is right about the internet. People expect much more today. And I think you and this group are trying to provide that. But I also think that we're dealing in it, we as physicians and trying to train our trainees are doing things in a different way. And again, it's because of Medicare and Medicaid. In our day, and Scott is part of that, the ward was the ward and the private service was the private service. And when you were on the ward service, you devoted your entire life, 24 hours a day, 7 days a week, to the care of these patients. Now they're almost the sideline. And I think when you're into them in that way, it was a lot easier to be, number one, professional, to get down to their level, and to explain things to them in the way that they could understand it. Because you didn't have anybody else to talk to. And I think that we make a mistake by, and Scott and I have talked about this before, we make a mistake in babying our trainees. Mm-hmm. And trying, instead of just throwing them in there, there is an advantage to that. Throw them in there and make them sink or swim, dealing with these people. But obviously observe them and provide them with people. But I think we've got to let them sink, got to let them swim by themselves.
As long as the patient doesn't sink.
Well, I think EHOP is probably the best example that we have of letting our students get in there with the truth, with the patients, with very little outside. Yes, they have supervision, but it's the least supervised of all of the activities that I see from our medical students and residents is EHOP. And our residents are much too carefully supervised today. And that goes, that's way beyond the scope of this Institute for Medical Education or any given round. But when there was less supervision, you had to be the doc, because you didn't have anybody to fall back on. And you had to sink or swim. And I think you learn by the seat of your pants. Learning by the seat of your pants.
So the ownership.
And you had the ownership. Right. I mean, they were your patients, and there was nobody you could call for help, but they were your patients.
So from a I'm looking at from a non-patient perspective, and so thinking of a socioeconomic, population may not be able to afford a computer, let alone find that information, that you're illiterate as well. And the patients that you see at IMA are not these people. In addition to that, you look at, if you're sending them out into the community, they're looking at who these patients are, where they live, what they eat. And I myself was a patient in the nutrition department, and I was handed a menu of foods that are not culturally,
relevant.
My culture, I'm Puerto Rican, and I got a list of things that
you're not going to eat.
Empanadas and all that. And I've actually seen that in other clinics here. So again, although you want to throw them in there, from a patient perspective, it would be helpful for them to meet them halfway.
David.
So, thanks for coming and giving this talk. See, from my perspective, one of the best things about something like this is that you force the residents to slow down and stop and think, as opposed to what they do the rest of the time, which is run around and do. But at the same time, I think that I guess I wonder what you think, because where I see the inherent difficulty in delivering this to a group of house staff, right, who've just come off the MICU or just come off the MICU, is that two things about this I think run completely counter to everything else that they're learning. Because everything else that they're learning is the explanatory model that they're not hearing from the patient. So as soon as they hear something that's different, they somehow have to wrap their heads around taking everything that they've been told to do. This is how you work it out, this is how you treat it, this is how you... and possibly even putting it aside and saying, well, if diabetes is not your priority and your gout is, then let's just talk about your gout today, and I'm not worried about your people. And that creates enormous tension, I think, in their mind.
Absolutely.
And the other one, I think that even the ones who know this and buy into it, as soon as they walk out of the room, are faced with the time pressures we're all faced with.
Yep.
So that if this takes an extra 90 seconds, you start to break into a cold sweat.
Yeah.
Because your patients are waiting, you've got to get back to the wards. And so I wonder if you feel those.
Oh, absolutely. I think I'll address the first one, which is the issue of the sort of what we're trying to tell them to do here and what we're trying to teach them is very sort of counter to what they've been experiencing. And so it is countercultural in that way because it is very not what they've been doing, especially when you're on the wards. And that does make it harder for it to sit with them. We have tried, sometimes successfully and sometimes not, to have them pull in a patient and make it more relevant to them by thinking of a patient that they've had difficulty with, adherence issues or a variety of issues, and try to see, okay, to tease out where in this patient's culture could this be relevant. What in this patient's culture could make this particularly difficult patient relevant to you from this cultural standpoint, and what can we try to do to make it easier so you're not feeling like you want to run screaming from the room every time this patient's name shows up on your schedule. That sometimes works and sometimes it doesn't. Because sometimes people feel like it's way too much of a stretch. Other times you can see the little light bulb going off, like, oh yeah. So that's a little bit mixed. But in terms of speaking of how it jives with the medical culture, it's very hard to fight. I feel like Sisyphus. Sometimes, rolling the rock up the mountain and having it roll back. So that's challenging. The time issue we have tried to address, albeit not always so successfully, with the residents by saying, if you don't address the gout first, and you just want to address the hypertension, for example, right? They'll just be back about their gout, and then you'll be frustrated. Or they'll be back, but they won't have done anything you wanted them to do for their hypertension because they were caring about their gout, and you didn't address that. Sometimes that goes over, and sometimes it doesn't.
Sorry, to follow up on a couple times a year they have this thing called Numbers Day, where all the chairs of all the departments got 3 hours lunch. About the most painful thing you could possibly do. But I would say half of what Ken Davis and Dennis Carney and all the security people here, probably half the time they spend presenting the chairs with data on how their faculty are performing, and an enormous amount of it now, I'm sure you know, is becoming more and more driven by patient satisfaction. You know what I mean? So maybe there's discussion over hemoglobin A1Cs and things like that, but patient satisfaction drives everything now. Reimbursement to the hospital, reimbursement to the individual faculty member, and I wonder whether there's a way to help residents understand that for the rest of their lives, unlike what was like in the old days, for the rest of their lives, their whole clinical life is going to revolve around patient satisfaction. And a huge component of their patient satisfaction is not if the hemoglobin A1C came down, but the patient felt like somebody listened.
Yeah.
So, that may be the time.
Yeah, we've tried to talk to them about, we've actually presented papers about patient-physician communication, and we've sort of retitled and retooled this to be maybe reflecting a little more of what Scott is saying. And rather than cultural competency or which is what it's titled or was titled, this year we changed it to culture and communication to really address this issue of communication and that it's culturally related, but not to use the competency because it has this negative overtone for people. I have to say, my experience with them, and I'll speak in 1 minute, Scott, they haven't been that excited. We've shown them papers, because they're very into EDM, right? Show me the data. About how if you don't communicate well with your patients, it leads to poor outcomes, it leads to more frequent visits, it leads to a bunch of things. And they're like, okay. And then kind of just, I think that unless they're being graded, and unless they're being evaluated currently on their patient satisfaction,
sit down with you for an hour and show you where, not just this hospital, where all hospitals are headed in terms of this kind of data, he will make it so compelling because this is going to end up right in their pocketbook.
Yeah.
Because if they can't do this well, they're reimbursing them.
You got to get them to understand that.
I was just thinking that you would have him show you what they use for the faculty and have them use that with their own patients and do their own patients. They have to have something directly to that to show.
But I mean, I went to a workshop last year where one of the family medicine programs, so as part of the ACP's outcomes requirements, includes all of the things on the faculty dashboard for every resident in the ambulatory practice. And they present each person with their data point, including patient satisfaction and the whole bit. And the
test points that Ira and I are working on. There's two very big places, UCSF and Yale, tie the resident compensation. They each have a pool of money. UCSF has $1.2 million.
Wow.
That the resident, if the hospital meets its quality indicators, the residents share the $1.2 million.
Wow.
And so, you know, we can make it very concrete, and Ira and I are actually going to meet soon about that. But and the last thing is, there's a part, medicine is required to do 2, maybe 3 EXs a year for the training program.
Yeah.
Is that occurring in the ambulatory?
Not usually.
Because if you did in the ambulatory service and you reworked the questionnaire and you did the if you reworked it, the communication piece includes all of your components, you'd be able to really track that.
Yeah. It doesn't, they usually do it on inpatient, but it definitely is a good thought. We had in the past done it in the outpatient, but it, for various reasons, didn't take hold. But that is very interesting. I think the one issue about tying compensation for residents to the patient satisfaction is that it is so disjointed, as you said, in IMA and residency clinic, despite the fact that we call it continuity clinic, often is not a continuous clinic or practice for many of the patients and sometimes many of the providers with regards to taking ownership of patients. And so that can be potentially a tricky issue, but trainees, in my experience, who take more ownership of a larger pool of patients tend to be better at this. And I think it has to do with issues of feeling this connectedness.
I can tell you, UCSF, they meet every one of their benchmarks for quality every quarter.
Wow.
I just want to make one comment as well. We have to end.
Oh my God, I'm so sorry.
But I think that also, as I'm listening to you talk, I'm hearing so many talks about things I've done for the residents, and I do find it also, the residents and the residents that, and I'm sitting here realizing that, I think we need to just cut them some slack and say, you know what, I have been taught the explanatory model multiple times, or sat it on something. Every time I am taught, I go, wow, this is so great. I use it for 2 weeks. And then I'm triple overbooked, and it's gone. And then I use it next time, I need it, and then I'm triple overbooked, and then it's gone. But every reminder does remind me to do it. And so I think that when you think about what can we do to incentivize the residents globally, right? Just think about what would incentivize us. And then that's, I think, how we should think about how to incentivize them.
Well, you can't incentivize them because of their time constraints.
Right.
And I think David put his finger on it. It made me think a little bit. We may have been in the hospital on call working 110, 120 hours a week. But we had more time to deal with individual patients because patients were sick. They weren't all that sick. They sat there for days.
Right.
We could spend hours with them.
Exactly.
Learning all about them, all about their families. And the residents don't have that
No.
opportunity today.
The length of stay is so short. I mean, the length of stay is so short, it's really hard. But on the outpatient side, if you do have a patient that you really feel like is yours, you do better. I'm so sorry I have to run. Thank you so much, Lisa.